Good morning, everybody. President, Deputy Vice Chancellors, Deans, faculty and guests. It's a real pleasure to welcome you all this morning to our second Sir Charles Cameron Award ceremony. This award was raised to mark the establishment of the School of Population Health at RCSI, established in 2021. The first recipient was Dr. Mike Ryan, from the Executive Director of the WHO Health Emergencies Programme. And I'm really delighted to welcome our second recipient, Professor Andrew Morris, CBE, Director of Health Data Research UK, who will be formally introduced by our Foundation Head of School, Professor Ed Gregg. But can I start by taking the opportunity to congratulate Professor Gregg and his team at the School of Population Health on a truly outstanding first full year of operation. I'd like to particularly call out and thank our leads in the Division of Population Health Sciences for their contribution to this success. Professor Anne Hickey from Health Psychology, Professor Debbie Stanistreet from Public Health and Epidemiology, Professor Kathleen Bennett from Data Science Centre, Rory Brewer from Global Surgery, Professor Jan Sorensen from the Health Outcomes Research Centre, and Dr. Sarah Berry, our Education Lead, Elaine Healy, our Research Manager, and Brian Flood, Operations Manager. And I'd like to particularly call out and recognise our Deputy Vice-Chancellor for Academic Affairs, Professor Hannah McGee, whose vision it was to establish the school and has worked so closely with the school leadership team to give it such an outstanding start. The award ceremony itself honours our past president, Sir Charles Cameron, who made it his life's work to improve the health and well-being of Dublin's most vulnerable inhabitants at a time when infectious disease was rampant and mortality rates in Dublin were among the worst in Europe. He served as Chief Medical Officer of Health from 1879 to 1921. He simultaneously held the Chair of Public Health in RCSI from 1868 to 1920, using this platform to educate and influence future generations of healthcare professionals in the area of population health. His efforts focused very much on housing and sanitation, public education and food safety. Cameron's efforts saw the death rate in Dublin decline by a quarter between 1901 and 1911. Serving as president of RCSI in 1885, he was a true polymath, ahead of his time. In fact, he epitomised the One Health concept, writing in 1892, and I quote, "The medical officer of health will be something more than a physician and a surgeon. He will, in sufficient degree, be bacteriologist, a chemist, a veterinarian, a geologist, an engineer, a statistician, and as so far as the sanitary structures are concerned, a lawyer." I think it's entirely fitting that we associate his name with current and future leaders in the School of Population Health. And now it's my great pleasure to welcome the Foundation Head of the School of Population, Professor Ed Gregg, to the podium.
Good morning, everyone. It's nice to see you all here. It's my honor to actually introduce Professor Andrew Morris to give our Cameron Award talk. Now, Andrew comes from University of Edinburgh, and he's seconded to what's called HDR UK, Health Data Research UK, and you'll hear about that, I'm sure. Andrew received his medical and research training at University of Glasgow. He went on to a professorship and eventually deanship at University of Dundee in Scotland before going to Edinburgh. Now, I actually met Andrew about 20 years ago. I was a staff epidemiologist at CDC. And we'd invited him to come talk because he was doing strange things in our mind in Scotland. And to sort of set you back in time a bit, at that time, what we were doing in population health research, I think was by comparison much narrower. We did surveys, and those were the surveillance people. And we did cohorts, and those were the etiology people. And we did trials, those were the clinical epidemiologists. And what Andrew was doing in Tayside, which is a region of Scotland, as you all probably know. It sort of sits on the map, kind of like Leinster does here, he was essentially putting all of these together into one integrated data system that was really allowing you to do all three of those things in one. And really go beyond that because it was allowing him to understand populations actually, representativeness in ways that our attempts at cohorts and effectiveness research was not. And the other thing that he was doing was he was fundamentally changing the concept of sharing data in my mind. And at that point, as maybe we still see, if you had good data, you hung on to it and you damn sure didn't share it with your colleagues who you were competing with. And what we saw with Andrew coming is in addition to treating and building data systems in a new way was actually, I think, creating collaborations in a new way. Andrew also had, just as an aside, I noticed a very satirical but warm sense of humor. I was in uniform, public health service uniform at the time, and I think he sensed that I'm not so suited to those sorts of formalities, particularly in dress. And he told me though that he told me he thought I had a great future as a decorated field commander, and and I felt quite proud of that. And of my uniform, at least for that day. So Andrew, though, went on to a next phase that was really amazing, quite prolific. He took what he'd done in Tayside and essentially led the scale up to Scotland. And with that, I think he also increased the breadth, the impact of what Scotland was doing, and actually became really world leaders in chronic disease epidemiology, in health services research, in effectiveness research, in genomics and multiomics. And during this period, Andrew amassed more than 330 original articles, more than 50 million in grants, led numerous program of grants. There's many accolades that I know he won't want me to take you through, and I'll spare you that, except he served as Chief Scientist of the Scottish Government Health Directorate. He's a Fellow of the Royal Society of Edinburgh, Fellow of the Academy of Medical Sciences, and a CBE, which is Commander of the Order of the British Empire, which is a more esteemed commandership than I had for sure. But Andrew then moved in really to, at least I see as a third phase, and starting 5 years ago, he became head of HDR UK. Now, with that, he built on those original concepts of data openness, connectedness, the multidisciplinary aspects, and the way we could influence health, but really dramatically expanded the scope and impact. So it was more than about what we do in traditional population health science, but really affecting literally all of health. As he'll describe to you, HDR UK actually unites virtually all the academic institutions and virtually all researchers in health in the UK, and has helped made it what I think is right now the strongest country in the world in terms of data for health. So I will. I don't want to steal his thunder, so I'll let him share, as I'm sure he will, what HDR UK does in part, as well as maybe what the future looks like. And finally, in spite of his amazing accomplishments, Andrew is apparently capable of some absent-mindedness. We almost did not have him here this morning. He missed a flight out of Birmingham last night, so was going a little sleep. He fessed up that he showed up at the airport with his wife's passport. So I, in turn, fessed up that he's in good company. I once showed up in Edmonton, Alberta, with no passport at all. But if Andrew has any trouble getting back for whatever reason, I tell him that we're happy to have him and we're happy to keep him. His wife may not be so happy. But I'd like to, with that, hand this now to Andrew and welcome him and congratulate him.
Thank you, Ed, for that generous introduction. And it's great to be in one of the world's great capital cities. And a real privilege and honor to be remembering the Cameron, who was a pioneer. And what I want to do today is firstly thank Cahill, Laura, Hannah, and the inaugural dean. Are you still on probation, Ed? But actually, Ed has asked me to challenge you today. Firstly, by looking at what I call trends in data science and technology in healthcare, and biomedicine and how that impacts on public health. And then secondly, try to convince you that if we really are going to harness this opportunity, and I talk about data as infrastructure, then it requires collaboration on a scale not been seen before. And I'm going to suggest that Ireland is going to be, is really well placed to do this for its population of 5.1 million people. So that's the script. But I thought I had to say, through gritted teeth, this was, the weekend was hard for us in Scotland, as you see. What I like, as you know, Scotland are very consistent, especially with a score of 7. Because both the senior side and the under-20 side only scored 7 points. And this was personally very hard because my son was playing number 8 for the Scottish under-20s. But can I credit, you've got amazing talent. And it's the same in biomedicine. But Sam Prendergast, I don't know if you know him, but wonderful player, wonderful. He's a real, he's the new Dupont. So I think we can credit rugby to the Irish, and good luck on Saturday. However, I said that Sir Charles was a pioneer in public health. And as you can see, Scotland is going to claim Cameron. Because he was a Stuart, and he was from the clan Cameron. And I'll talk a little bit about Cameron later, but this was one of his quotes. But the thing that comes across about Cameron is his humility. He was a polymath. He was a pioneer. He embraced all the disciplines that Cahill talked about, but he had great humility. His friends were saying, go and publish a book, they said. He says, after much hesitation, I have the temerity to do so. My hesitation arose from reflection that although I hold some public positions, I'm not in the broad meaning of the phrase a public man. So he had humility. Contrast that to some of the behaviors during COVID. So what am I going to do? So I'm going to talk about 3 things today. I'll try and talk for about 25 minutes. Firstly, talk about the pace of change. Secondly, gearing an entire country up for health innovation and research using data science as an enablement or empowering feature. And then lastly, suggest it is time to be bold, ambitious, and enterprising if we're going to serve the publics and serve the publics well. So definitions are important. So data science is a phrase I'll use. And to my mind, it's the interface of mathematics, statistics, computational science, and domain. And our domain is medicine, biomedicine, public health. So how many mathematicians in the room? 1. We say that's an outlier. So how many statisticians? 1. Any computational folk? And domain, the rest of us, I guess, in terms of public health specialists. So in terms of healthcare delivery in the future, interdisciplinarity is going to be key. So when I come back in 10 years' time, maybe, if I remember my passport, we'll see how many interdisciplinary folk we've got in the room. So let's talk about the pace of change. So Ed says you can show us a bit of history. So this was me in the ward this is when I was a junior house officer in Glasgow. And you often forget, living through medicine and what a privileged career it is. This is a Bill Gates quote. Most people overestimate what they can achieve in a year and underestimate what they can achieve in 10 years. And Laura and I were discussing this over coffee. And it's the same in our biomedical lifetimes. So just to illustrate that, what did we not have when I was on the ward? The Glasgow Coma Scale. That was Teasdale and Jeanette. MRI didn't come in until 1984. We used to send people for isotope brain scans, and it was like the weather forecast. You didn't know what it was saying. Statins, 1986. Laparoscopic surgery, very relevant to this institution, wasn't really prevalent to 1990. And I love this slide because to me it explains why you can never find a surgeon in a hospital. So, smoking, public health, smoking ban in public places, and more recently immunotherapy and immunodiagnostics. So in our lifetimes, It'll be amazing, the transformation. But I'm going to argue that it's going to get even quicker. So the pace will get quicker. Has anyone been to this place? Ed, you been there? Where is it, do you know? Oh, well done. Well done. Who said that? That's really good. Yeah, clearly Ed's not been invited yet. So, so if you go to Davos, the World Economic, Klaus Schwab and his mates talk about the fourth industrial revolution. And this isn't just a migration from the third, the sort of IT and tech age. It's the fusion of biology with physical, computational, and behavioral sciences. And what we're seeing is it's a new era, and I'll try and convince you of that. Why is it? Firstly, it's affecting every industry in every country. Secondly, it's very disruptive. You know, the death of the high street. It's undermining democracy, Cambridge Analytica. And lastly, the pace of change is exponential rather than linear. And this is coming to healthcare and biomedicine now. And the challenge is, how do we embrace this in a trustworthy way? And I think trust is key to this. And just an illustration of exponential change. So this is a graph of ChatGPT uptake, and you'll see it had 1 million users within 5 days of being launched. Who here hasn't used it? Oh, that's quite all right. So you're in the minority. It actually took 30 days to reach 100 million users, and it took Netflix 20 years to reach 100 million users. So ChatGPT is exponential. And what we're likely to see is subspecialization of AI, and we're beginning to see that already. So this was a DeepMind Google research endeavor using large language models. So what large language models are is a way of self-learning or deep learning on complex data sets. So ChatGPT-3 is trained on 184 billion parameters from the internet. ChatGPT-4, which will probably come out in the autumn, will be 1 trillion parameters. But what we're beginning to see is subspecialization. And here's the first example. It's a beta version, but Palm is actually trained on medical literature. And what they did is trained it on about 540 billion parameters, then asked it to sit EDS exams in the States, and it passed. So this is the beginnings of how we apply AI at scale. But actually, if you look at technology and the subspecialties of technology, what we've seen in the last 15 years is that acceleration. So in our world, in diabetes, we've now got GLP-1 analogs. We moved on from metformin. We've got different, in renal medicine, in surgery, there's progress. But there's been a similar progress in what I call subspecialties of technology: sensors, robotics, natural language, speech recognition. And what we're also seeing is a remarkable confluence of those technologies to create products. An example is 2 years ago, there were 11.3 billion active Internet of Things devices. So these are things which are connected to the internet. And that will increase to 30 billion by 2030. This is one of our former prime ministers. As you know, we go through them quite rapidly, being shown around the UK supercomputer. And last week, the UK has said, we're going to invest in exascale computing, and that's 1 billion computations per second. And what we're beginning to see is this confluence of big data, as I've explained, being supported by computation. And that will be transformative in terms of how we deliver healthcare. But where are we? So this is an Ara Darzi slide. He's a very distinguished alumnus of this institution. Because Ara and colleagues mapped, who's leading in data science and adoption of AI. And as you'd expect, high-tech telecoms, fintech are out there. And at the moment, health, as you can see there, is mid-table. So it's a bit like Manchester United. It's not. But what we're seeing, as I've suggested, is this huge investment in AI and data science at scale. The other comment about that is who's putting in the investment. We spend it's about $400 billion a year on AI and data science. And it's actually not the universities, it's not the governments, it's technology companies. So I see you had Karen DeSalvo here. So thinking through, and I call them G Mafia. So Google, Microsoft, Amazon, Facebook, IBM, and Apple. That's where a lot of this research and development is taking place. And the secret will be when we can merge that capability with health system domains at scale. And I talked about scale, and this is why I think at the very least we should be thinking about what can we do on an island-wide basis. And to illustrate, this is Rory, who leads UK Biobank. This is the relationship between blood pressure and mortality in the Framingham study, which is one of the most famous, 5,000 people. So you can sort of see the relationship. That's 50,000 people. That's UK Biobank. And increasingly, scale is going to be important. To take another clinical domain, cancer and the trials of cancer. So as you know, we're beginning to understand the etiology of cancer based upon biology rather than clinical presentation. You know, in my day as a medical student, there were 4 types of breast cancer based on H&E staining, as you could see down the microscope. There are now 132 based on etiology. But then, as we dissect common complex disease, we've got to think, how do we assess safety and effectiveness of new therapies? So this is a bit of a thought experiment. But say we wanted to do a clinical trial on 250 people in a year with incident cancer with a specific biomarker frequency, and most are actually below the 1% level. And as you can see, for common cancers such as lung, you need 42 million people, pancreas, because it's a rare cancer, 225 million, and primary hepatic cancer, almost 500 million people. So we're going to need to collaborate at scale if we're going to benefit these patient populations. And then finally, why is this important? The UK is really struggling with productivity. And we actually touched upon this in our discussion. So we've fallen off a cliff. The dip there is the pandemic, but it actually goes back to 2008. Our productivity is very low. And our health system productivity is even lower. And this is causing catastrophic challenges to the health systems. And one way to increase productivity is to invest in infrastructure, data, training, and innovation. So this is not only relevant to research, but we've got to think, if we're going to see a convergence of care and research, it has to improve the patient experience and the productivity of health systems. So that's the sort of background. But I would argue, this is Leroy Hood, who helped to found the genome. If we do believe in 4P medicine that's predictive, preemptive, personalized, and participatory, we've got to have a real focus on those enabling technologies, which are genomics, phenotyping at scale, data science, and analytics. And that's the proposition. Saying that, you must always be conscious of context, and I currently talk about 4P society, which sadly is Putin, pandemic, and the UK public sector unrest and pressure of inflation. You don't need to take photos. I give all my slides. You can have my slides if you want them. So that's the script. And what I'm going to describe now, how we're trying to see this convergence of care and research in the UK using data science as a catalyst so we can run studies and support care on 66 million people. And that was the basis of this thing called HDR UK, which is a national institute. And we're about 5 years old, and all credit to the funders. We've got 9 funders who, instead of balkanizing research support, said, we need to come together and do this once, do it well, do it for the nation in anticipation of the fourth industrial revolution. And our mission is quite simple. We don't want to be famous, but we want to enable great science and be a champion of open science and empower clinicians, researchers, surgeons, innovators to do great stuff on data. So our mission is to unite the UK's health data to enable discoveries that improve people's lives in anticipation that this large-scale data and analytics will actually transform the translation of research into care. And we're in the foothills of where we need to be, but that's what we tried to do. But we actually looked out with healthcare to look at other what I call data ecosystems. Now, our data ecosystems, as Ed suggests, tends to be very bilateral. You've got someone who's got a data set, you've got a researcher, and they have a very close, intimate relationship, and there's no sharing. Patients don't expect that. If you look at other data ecosystems, there's a sector maturity which enables the data as infrastructure. And some of it's not very attractive stuff. You know, it's about governance, policies, trust, public engagement, data standards. But you need that infrastructure to allow science at scale. A good example is financial services. I could send the president 100 euros. I'm not going to. In the next 2 minutes, because your bank, my bank, are highly competitive, but they've got SWIFT, which sorts the middle bit out, the messaging, and therefore you've got a trusted ecosystem. So I know that I confidently can send you 100 euros. We need the same in the way that we support patient journeys across journeys of care, but also for biomedical science, a many-to-many relationship. So we're a bit funny, where we say we're an institute without walls. We're institutionally agnostic, because if we did this from Cambridge, Oxford, Glasgow, Edinburgh, all the other universities would run a mile, because we're taught to run a mile. So we are a charity, we're UK-wide, and we really focus on this enablement of standards governance, and we're a partnership organisation. We've got a strong independent board, including Ara, who is an alumnus of this place, Mark Walport, a multidisciplinary board. So Alison was former HR director for BT. Because this is not only research, it's about services. And academics aren't too good at services. So you need that interdisciplinary expertise. Our community is, we've got 9 regions across the UK. We've brought together 38 universities under a single contract. But this is a people project, not a technology project. We've got fantastic leadership across the UK. And giving people the opportunity to lead on a broader canvas really incentivizes creativity. So we've got fantastic leadership across the board. And our ambition is shown schematically here. As I've talked about, it's about scale, so 66 million people. It's about detail, but you need exposure and you need outcomes. You need longitudinal, event-based, alongside journeys of care. But then, in the early days, I said, well, if you can't visualize it, you don't know. So I said, let's map this out. And I looked at this, I went, oh no. Because our data ecosystems are really, really complex. You know, and I thought, how is this going to work? But then I went to Holland, and they're just the same. And Ireland will just be the same. But the folk who can sort this, the connectivity and the coordination, will deliver value to their citizens. Because otherwise, the biggest risk, well, I remember my biggest risk with people with diabetes is what we call the handoffs in the system. It's when, you know, they go from primary or secondary care. We did a survey once, and, you know, I was very fortunate to work with kids with type 1 diabetes, and they said, the place we feel most unsafe is in the hospital because they take my insulin away from me. So this coordination is good for patients and good for research at scale. The final part of this is the multidimensionality of data. because we often focus on the middle blue blob, the health data, the electronic health record. But actually what we saw in the pandemic was the value of linkage of data from behavioral scientists, from economic activity, from footfall activity. So this next 5-year phase is not only going to focus on health data, but look at environmental, social, biological, genetic. Because in 5 years' time, most of the data will not come from the health system. So that's the thesis, and we do it in 3 ways. We've got triple aim, infrastructure and services for data. Secondly, I think if you have build it and they will come, people won't come. So some great UK-wide exemplars of so-called driver programs. And then thirdly, how do we enable collaboration and partnership on a scale not seen before? And actually, we've got joint leaders of our EHR multi-omics program between Oxford and Cambridge. And that's the way it should be. We say collaborate at the interface, compete at the implementation. So we're really key. So we've got a triple aim. And a big part of this is the infrastructure and the services, because a data ecosystem is trying to do 2 things. It's trying to do something which is quite simple. It's trying to connect research and innovators to data. So content providers with consumers. And in the early days, we worked with Doug Gurr from Amazon in Europe. And he said, well, that's what we do with Amazon. They connect content providers with consumers. But what you need is a whole set of policies, systems, expertise, the science of the infrastructure. Plus you need a collaboration, and we call it the UK Health Data Research Alliance, where 80 organizations have all signed up to say, we will share data based upon that stack. So that's what I call the infrastructure. And I'll just go into this in a little bit of detail, because trustworthiness is key to this. And if you've got lots of data travel, no one really knows what's happening. So we've adopted the 5 SAFEs framework: safe people, safe projects, safe settings, safe data, safe outputs. So we can provide assurance to the publics that we're using their data in a trustworthy way. So these secure analytical environments are key. And to do that, you need to have these services for data discovery, data access, data environment, data analysis. Now, in universities, everyone thinks this is the hard stuff, slightly boring, and it's someone else's problem to sort out. But actually, my argument is if you do it well, as a nation, it can be enabling. And we've managed to bring together those capabilities. So these are so-called trusted research environments. So we've got one in Scotland, Wales, Northern Ireland, and England. We've got ONS as well. But a bit like the banking system, you need a gateway to unleash and make it all available. So that's what we've done. And what we want is a low barrier to entry and a level playing field. So if someone's got a good data set, they can come and, doesn't mean that data is freely available, but it's fair, findable, accessible, interoperable, reusable. And then we've got a gateway that anyone in the world can access to say who's got data on, for example, diabetes, and then can request access to those data for research and innovation. So what type of data do we have? So this is a tapestry, but it includes UK-wide, population-wide data, NHS regional data, so we've got huge medical imaging, laboratory, natural language type data sets. We've got administrative data. We work very closely with Ian Diamond in ONS. Then we've got the cohort data, the trials data, and increasingly environmental, geospatial, and personal data. And that requires this set of infrastructure and services that no one else really wants to pay for or do. But I would argue that this is it's like power stations on the grid. So we're providing the grid to enable stuff to work. So the second bit of this is research driver programs, and UK-wide, we've got programs in inflammation and immunity, molecules to electronic health records, common complex disease, that's cancer, CVD, respiratory, pandemics. So you get this. But the key to this is two things. Firstly, to do research UK-wide that single universities can't do themselves. But secondly, leave a legacy, clean the pipes of the infrastructure so that we experiment and improve the machinery that underpins it. So we've been going, this is, in the first 3 years, this system enabled about 2,300 papers, 66,000 citations. So academically, it's fine, it's a bit of a juggernaut. But key is impact on patients and policy, which I'll touch upon. Then the third bit is this team science approach. So we've got 9 regions in the UK. So we've got Scotland, Northern Ireland, Wales, etc., and across. We sit in the Wellcome in London. Sadly, we don't have the whole building, but we want to stay very lean at the centre and actually invest strategically across the partners. And actually now, through the support of Gates Foundation, we've established HDR Global, which I'll touch upon later, because every country in the world is facing the same challenges. Training is a big thing, which I'll talk about. Equality, diversity, inclusion is a huge thing. And this, we worked with the City of London. They have something called the 10,000 Black Internship Programme. And we said, we're going to do this for data science. And this has been remarkably successful. We're now on the third spin of this. And we've got evidence that the black interns go on to do PhDs, masters. And it's really opened up a huge skill set that we were completely unaware of. Values is a big thing on this. So we talk about transparency, optimism, respect, because this is an enabling institute. We don't want to be famous, but we want patients to benefit from science at scale. And public engagement, involvement, deliberation is actually threaded through everything we do, through our public advisory boards and other such things. In terms of the money, because that's important, we were awarded 53 million, which is a lot, but isn't a lot of money. We leveraged another 108 plus about another 90 in kind. So we're about 250 million. So that's the approach. And the last 10 minutes or so just give you a case study of how it worked. So COVID, it's a great case study. In the early days of the pandemic, researchers were great, but there was no coordination or connectivity. So working with Patrick Valance, who you may have heard, he was the CSA, he came to us and he says, I want you to sort the data and connectivity for COVID for the UK for research and innovation. So we did 3 things. We mapped it, we enabled this infrastructure I talked about, then we made the data fair so that folk could see it. And in the early days of the pandemic, sorry, the fonts come away, but those are the 4 so-called trusted research environments in England, Scotland, Wales, Northern Ireland. Our data was very fragmented for COVID, and it was, it wasn't sorted. That's a busy slide, but I just want you to look at it visually. This is how it was 12 months later. We enabled these data sets at scale, and we included behavioral data, COVID opinion survey data, census data, labor force survey data. And this was a really great platform. The UK made many mistakes in the pandemic, but in terms of understanding the pandemic and research during the pandemic, we had, the team did a really good job. We reported to the government weekly, fortnightly, very collaboratively. So this was data research supporting the pandemic, reported weekly. And we showed who was doing what studies, what the access times were, et cetera, across the UK. So a few case studies of that. This is Aziz and Julia. So we did this for the UK, but with a focus on Scotland, because it's a similar population of Ireland. Aziz and colleagues linked primary care data vaccine status, antigen status, hospitalization, morbidity, mortality, comorbidity for the entire population of Scotland. So you remember the vaccines came in sort of mid-December 2020. So by the 16th of February, so within 6 weeks of the first vaccination, they were able to describe that a single dose of Pfizer and AZ reduced hospitalization by 85%, 94%. And that allowed countries across the world to change the dosing interval. So nationwide data. And we applied that to effectiveness, variants, vaccine waning, vulnerable groups, data as infrastructure enabling description of the course of the pandemics. And it was picked up. It was picked up all over the world. We were also able to describe that Omicron, remember R of Omicron was sky high, but actually in terms of its morbidity was less. So within 4 weeks of Omicron, we were able to say, actually, we're not seeing the uplift. Again, through linkage. So it was really that virtuous loop of research informing policy at a national scale. So that was a Scottish example. Under Cathy's leadership with Nilesh, we have the BHF Data Science Centre, which we pivoted to COVID. So we've set up a TRE, Trusted Research Environment, for the whole of the NHS on 56 million people. And this Venn diagram shows the power of linkage of these data sets based upon a unique patient identifier. So we're able to describe mortality in the early days of the pandemic for 56 million people. For 48 million people, we're able to describe what was the absolute risk of VIT. You remember the vascular complication of cerebral thrombosis, which was inferred by the AZ vaccine. And we're able to show that it was much less than the risk of COVID itself. So safety and effectiveness. And more recently, long COVID. How long is long? So this is a study, again, on 48 million people in circulation, showing that the longevity of long COVID, and it must have been important because it was published in our premium medical journal, The Sun. Urgent warning to anyone, aftershock. So, but then it's the same model. We can look at non-COVID pandemics, for example, cardiovascular disease and cancer. So what was the non-COVID related harm? This was in Nature Medicine just a few weeks ago. 500,000 people failed to have incident intervention for hypertension, lipid lowering. And again, this has actually led to Tesco to offer free blood pressure monitoring in the population. But then we use that same infrastructure to look at other issues. So we've now got nationwide prescribing that's linkable, and we're able to look at valproate, which, as you know, is associated with neural tube defects during pregnancy. And this has led to an intervention on a nationwide basis based on the Cumberledge report. Trials it can enable, so this is Martin, Marion, and Peter, who read the recovery trial. The thing about the recovery trial, it was enabled by data. Ascertainment of outcomes was entirely through linkage of data. So you don't need a squadron of researchers going around to say what happened to that patient. And it was very effective. So that was, I think, about 50,000 were recruited to recovery, but we didn't need to worry about the follow-up, the ascertainment of outcome. And as you know, dexamethasone was the first drug to be shown to probably, to definitely reduce mortality at the same time as reaching for the oxygen bottle, probably saving about 1 million lives globally. Again, data-enabled trials. Surveillance, we talked about, this is the Diamond. Working with the ONS survey, we can then use those cohort data and link in terms of, again, long COVID or the morbidity post-discharge from hospital and the fact that 30% of patients were readmitted with a mean follow-up of 140 days. So you get the idea. So we're now applying this to those other driver programs, so we have nationwide ability to harness data at science. And in COVID, we really did see an integration of research with policy, with service and the public, which influenced policy internationally. And I said that this is an international problem. So Steve Kern, who's in the middle there, led quantitative sciences at the Gates Foundation. And basically he said, we want to do this for the world. And we have a lot to learn from Brazil and Africa and Asia. So this is a very special collaboration where we have 12 of these driver projects internationally, linking data from 60 countries, which has really brought international teams together based on national instances, mostly of data infrastructures. And a couple of examples of that in Nature Human Behavior. A couple of weeks ago, we managed to harmonize data from 52 million births globally to look at the effect of lockdown on preterm birth and stillbirth during the pandemic. And this is some work which we did in collaboration with Harvard, resilience of health systems in 10 countries. So starting to, with humility, take this model internationally. So finally, ask, is it time to be bold, ambitious, and innovative? I would argue there's no option. There isn't a plan B. What we're seeing is digitization is here to stay. And we as clinicians, as researchers, can either observe it or influence it. And I would argue we are duty-bound to influence it. As I said, health systems are not sustainable in their current form, where your country, Ed, spends over 20% of your GDP on healthcare. So we need to look at productivity. So digitization is here to stay. These technology trends, which I've touched upon, will accelerate. This relationship with companies is going to be very important in a trustworthy way. Diagnostic tests will be done at home rather than in hospital labs. And we'll see an acceleration of AI, not only in the specialties of radiology, but in terms of genetics, biology, patient flows. So a few thoughts, because I'm a big fan of Ireland, apart from your rugby team. You've got superb expertise and thought leadership with outstanding science, interdisciplinary and public engagement in public health in Ireland. Is there an opportunity to think through, can we do this as a nation? Because I think it's good for patients, and that's the bottom line. So a final thought. I will finish with the quote that Cahill used. The medical officer of health will be, he was polymathic, a physician, a surgeon, a bacteriologist, a chemist, a veterinarian, a geologist, even a lawyer. So he said that in 1892. If he was here on the front row today, I'm sure he would say, and a data scientist. So to do this needs a new way of thinking and incentivizing and collaborating. But I do think the new Einsteins will be the scientists who share. And finally, as I forgot my passport when we're setting up HDR, because the MRC spent a lot of time thinking, what are we going to call this new institute? So we'll call it HDR. So we launched HDR, and then the following day, I should have done it earlier, I looked at the website and I saw that Havering, Demolition and Recycling had HDR.com. So we had to use a little bit of MRC money just to sort of buy their domain name. But anyway, it's a huge honor and pleasure to be invited to receive the Sir Charles Cameron Award. He was a polymath, and we're with humility, and that doesn't always go hand in hand. I think you're really fortunate to have him as a former president, and let's carry his legacy on to the next 50 years. Thank you very much.
Thank you very much again, Professor Morris. I'm sure Cameron, who would have lectured in this room, would be very happy to have been here today. I know some of you are in the School of Population Health, but for those maybe who are not in the school, are not from RCSI, I suppose just to say that population health is one of our 6 areas of research focus. So when we launched the new school last year, our goal was really to establish RCSI as a global leader in education and research in population health sciences for the promotion of health in Ireland and beyond. And to achieve this goal, the school is rapidly expanding the breadth, depth, and funding of its research activities. It's developing new postgraduate programs in population health sciences, and it's developing synergistic partnerships across public, private, and community sectors to enhance impact and implementation. So as part of this, we will shortly be launching a Cameron Scholars Programme to catalyse and to sustain our growth. This 5-year programme of spending of over €4 million will fund academic, research, scholarship and technical positions. And these posts will help to build and to consolidate our ambitions for programmes of education and research in the school. Recruitment for the first of these positions, the programme manager, has just commenced, and we'll be recruiting for lecturer and postdoctoral positions in the coming months. So do keep an eye for further announcements, and if you've been here today, we have your contact details in order to keep you in touch with those developments. And so for now, it's my pleasant task to introduce and to explain the Cameron Award itself. It's on the table here. It's a commissioned sculpture for the Cameron Award by artist Jason Ellis. Jason is from Cornwall, and actually our speaker today has just reminded us that he started his medical education in Cornwall, so there's a nice synergy. But Jason Ellis, the sculptor, has lived in Ireland since the 1990s, and he works in stone, and his pieces are in locations such as Bantry House in Cork, the Druid Theatre in Galway, and the Gardens of Dublin Castle. And so in 1921, he won the commission from RCSI to produce the Cameron Centenary Award for Services in Public Health. So the sculpture you see here is alabaster on black Kilkelly marble. So it's abstract, but with a nod to a chemistry lab Bunsen burner flame, inspired by Cameron's first career as a chemist. I'm delighted now to call on RCSI President, Professor Laura Vianney, to present the Cameron Centenary Award to Professor Andrew Morris. This is, Professor Kelly says, this is the second sculpture. The first is sitting, hopefully, we think, in WHO offices in Geneva with Dr. Mike Ryan.